Good afternoon, everybody. Today we have our third lecture, and this lecture is Introduction to Evidence-Based Medicine and Evidence-Based Public Health. Evidence-based public health is an approach to public health practice that has evolved in part from advances in the field of evidence-based medicine. This lecture begins with a public health case presentation to set the stage. The intent of this presentation is to present an initial overview of evidence-based public health and evidence-based medicine. These are the main topics to be covered in current lecture. Rise of evidence-based medicine, development of evidence-based public health, current perspectives on public health, a new definition of evidence-based medicine and evidence-based public health, evaluating and improving, review of case presentation, and then after the basic overview of evidence-based medicine, we should to discuss how can we evaluate of diagnostic and screening tests and what should be done to estimate treatment effect. We will begin with a discussion of evidence-based medicine. Evidence-based medicine, first described in 1992, it was hailed as a new approach to teaching medicine and was once described in the New York Times as a revolution in medical practice. Evidence-based medicine has spawned a host of evidence-based approaches, including ethics, psychotherapy, occupational therapy, dentistry, nursing, and librarianship. There are some limitations of current clinical practice. Why should we change our current practices? Our patients like us. Our outcomes are generally good. We keep passing our board exams, and they keep telling us we have the best healthcare system. Besides, change is hard work. Aren't we busy enough learning about how to survive in a managed care environment? Unfortunately, this is good evidence that the quality of care we give our patients could be better. Such evidence comes from limitations of current clinical practice. Some of these limitations are shown at this slide. Clinical examples in which lack of good evidence has led to harm for our patients. Common patterns of thinking that introduce bias. The wide variation in current clinical practice among physicians. The difficulty of managing medical information then results conflict, and thousands of articles are published every month. Our knowledge declines over time as we get further from medical school. Let's examine some of the factors that have driven the development and use of evidence-based medicine. Clearly, one of the overriding factors has been the explosive growth of the medical literature. The development of the internet continues to expand the quality and availability of medical information. The problem has been how to quickly and efficiently obtain high quality information that is relevant to each patient or clinical encounter in both inpatient and outpatient settings. Textbooks, compiling a lot of information in one location are frequently out of date in key areas by the time they are published. Because of the overwhelming volume of medical literature, it has been difficult to sort through and extract what is needed to one's unique practice. Also, randomized controlled trials are expensive and time-consuming to conduct. Their numbers increase because they provide essential scientific information, particularly regarding interventions, which may carry significant risks. The development of an area of computerized databases and new evidence strategies has facilitates the growth of evidence-based medicine. At this slide, you see the easiest definition of evidence-based medicine. It was initially proposed by David Sackett and colleagues from McMaster's University in Ontario, Canada. Sackett realizes that evidence alone is not sufficient to the compassionate, effective care of patients. He stresses that the practice of evidence-based medicine requires that it be integrated with clinical expertise, which brings the following important elements: expertise in performing the history and physical examination, knowledge of the patient, the family, and the community, which creates a context for therapeutic decision making, a relationship with the patient informed by his or her beliefs and values, practical knowledge of the availability of resources in the community. Look at this slide. Evidence-based medicine is the integration of best research evidence with clinical expertise and patient values. It is a change in the way physicians practice medicine, teach and learn, and handle research. There are three parts in evidence-based medicine: clinical practice based on the best current evidence, not necessarily on how it's always been done; patient care, compassionate, patient-oriented, less authoritarian, more intense, investigative, less know it all by yesterday. And third part is the research, more stringent approach, better proof criteria, more demanding for proof, less room for error. At this slide, you see some arguments for evidence-based medicine. Taking an evidence-based approach to practice, teaching, and research can help you address some of the limitations of current medical practice. So So the argument for evidence-based medicine are shown at this slide. It can help you stay up to date with the current literature, communicate effectively with consultants, make the best use of other sources of information, such as pharmaceutical representatives and colleagues, make the best use of information from the history, physical examination, and diagnostic testing, avoid common pitfalls of clinical decision making. This slide, there are three major components of evidence-based medicine which construct question or problem. Um, Evidence-based medicine consists of a combination of physician, patient, and information. And if we overlap all these three parts, we have area of question or problem. In the overlap parts, we get some added details. From the patient, we take values, concerns, preferences. Patient has some expectations and life predicament. For physician, it gives training and experience, current expertise, continuing learning, and demand for proof. Information in this scheme is clinically relevant, proven by research, best up-to-date evidence. And there are transactions between all these three parts. At this slide, you see optional components to be added by the physicians. Charity means evidence-based medicine, not mandatory, not yet. Humility, evidence-based medicine is not for those who prefer an authoritarian practice of medicine. And enthusiasts have fun with the challenge, variety, and change. There are some questions we should ask. Isn't this the way we have always practiced medicine? Aren't these just the same old ingredients tossed into a new recipe? Then am I supposed to find the time to do that? Let's try to answer these questions. To process of evidence-based medicine, the process of evidence-based medicine has been described as a series of steps as follows. First of all, we need to convert the need for information about prevention, diagnosis, prognosis, therapy, and causation into the answerable question. The next step, track down the best evidence to answer that question. Third step, we need critically appraise that evidence for its validity, closeness to the truth, impact, size of effect, and applicability, usefulness of one's clinical practice. Integrate the appraisal with one's clinical expertise and with the patient's unique biology, values, and circumstances. Evaluate one's effectiveness in executing the first 4 steps and seek ways to improving one's evidence-based medicine approach. development of evidence-based public health. Janik noted that epidemiology was the foundation for both evidence-based medicine and evidence-based public health. Epidemiology describes as the foundation of both evidence-based medicine and evidence-based public health. Evidence-based public health unique is using complex interventions with multiple community and societal issues. Now I show you some definitions which differs a bit one from another. You can try to memorize any definition you want. Evidence-based public health is the explicit and judicious use of current-based evidence in making decisions about the care of communities and populations in the domain of health protection, disease prevention, health maintenance, and improvement. Key terms in this definition are explicit, means we should use defined methods. Judicious, we should use judgment. And best evidence means sort through the literature and identify what is useful. Another definition given by Bronson. Evidence-based public health is the development, implementation, and evaluation of effective programs and policies in public health through application of principles of scientific reasoning, including systematic uses of data and information systems and appropriate use of program planning models. Bronson's definition is somewhat similar to Janik. Critical terms in this definition include effective, implies that evidence determines that programs are effective. Scientific reasoning means relates to thinking and judgment. Systematic and models allude to the explicit use of defined methods. Bronson developed a model of evidence-based public health analogous to evidence-based medicine. Let's look at the next slide. These are the steps of evidence-based public health. Is described by Bronson et al. First, we need to develop an initial statement of the issue. Then, next step is to search the scientific literature and organize information. Then we need to quantify the issue using sources or of existing data. Develop and prioritize program options. Implement interventions. And then we need to evaluate the program or policy. Steps in evidence-based medicine look similar as presented previously. Here are the steps of evidence-based medicine for comparison. Convert the need for information, information and answerable question. Then track down the best evidence to answer that question. Then critically appraise that evidence for its validity, impact and applicability. Integrate the appraisal with one's clinical expertise and with the patient's unique biology, values, and circumstances. Evaluate one's effectiveness in executing the first 4 steps and seek ways of improving one's evidence-based medicine approach. Let's look at the parallels in evidence-based medicine and evidence-based public health. The analog steps of evidence-based medicine and evidence-based public health are highlighted here. So state the scientific question, identify the relevant evidence, determine what information is needed to answer the scientific question, determine the best course of action considering the patient or population, evaluate process and outcome. One of the key resources that has enabled the development and practice of both evidence-based medicine and evidence public health is the Cochrane Collaboration. Its mission is stated in this slide. Mission of the Cochrane Collaboration and International Cochrane Collaboration is an international organization that aims to help people make well-informed decisions about healthcare by preparing, maintaining, and promoting the accessibility of systematic reviews of the effect of healthcare interventions. At this slide, you see structure of the Cochrane Collaboration. The structure of the Cochrane Collaboration consists of the following components. Collaborative review groups contain researchers, healthcare professionals, and customers interested in particular health conditions or diseases. There are more than 50 collaboration review groups. Then methods groups exist to improve the methodology of systematic reviews. Fields focus on dimensions of healthcare other than health problems such setting. For example, primary care, defined population, for example, older people, or intervention, for example, different vaccines. Consumer network provides information and a forum for networking for consumers involved in the collaboration. Centers supports the work of the above entities in 12 centers around the world. Another important source of evidence-based public health is Guide to Community Preventive Services. The guide uses a defined evidence-based approach to develop recommendations for addressing a number of important public health problems. Supported by U.S. government Centers for Disease Control and Prevention based on systematic reviews and gives a recommendation based on the strength of evidences. The task force has published over 100 findings across 9 topic areas. This list of topics brings up one of the weaknesses of evidence-based medicine and evidence-based public health. The evidence-based for both is far more limited than the area of problems confronted in practice. But these 9 areas are shown at this slide. This is vaccine preventable diseases, tobacco use prevention and control, reducing motor vehicle occupant injury, diabetes, physical activity, oral health, social environment, prevention of injuries due to violence, and last area is the cancer. If we are going to be able to discuss evidence-based public health, we need to have an idea of what public health is. Public health encompasses, therefore, science, art, and approaches used by all sectors of society to assume, maintain, project, promote, and improve the health of the people. Components of public health are indicated at this slide. Individuals and communities are no longer passive recipients of public health services. They are active participants of the public health system. Employers and business is interesting in public health, and we should use media to inform community about scientific researches. Next definition of evidence-based public health, which gives by Kohatsu. Kohatsu recently published a definition of evidence-based public health, emphasizing three concepts: the process of integrating science-based interventions with community preferences to improve the health of populations. How can we evaluate and improve evidence-based public health in practice? These are the core areas in which evidence-based public health advances should be aimed: quality of the science-based, community involvement, and third, effect in public health outcomes. Improving the quality of the science-based supporting evidence-based public health can be addressed in many ways, including the following. Randomized controlled trials are well suited for demonstrating efficacy of a clinical interventions. They are less suitable for many public health interventions which have complex causal chains which may be tested in communities that are quite variable. May have to standardize their intervention by function, diabetes education to culture education rather than content. The trend statement improving the reporting quality of non-randomized evaluations of behavioral and public health interventions. The trend statement provides a checklist and description of elements that should be present in papers reporting results from non-randomized studies. It was developed along the lines of the consolidated of reporting trials consort, so-called consort guidelines, which are developed to improve the quality of randomized control trials. The GREAT system, GREAT working group, was developed in response to the variability of ranking systems used by various health-related organizations to assess the quality of evidence and the strength of recommendations. Ideally, an entire community participates in determining and addressing its public health needs. Here, staff of the Nepal Water Project, a non-governmental organization dedicated to improving access to high-quality water supplies for communities in Nepal, meet with community members. Increased community involvement in public health interventions, moving from passive to active involvement, is an ethical imperative. This slide highlights one of the 12 principles of the ethical practice of public health public health. These principles have been endorsed by the Public Health Association, the Public Health Foundation, and the College of Preventive Medicine, among other organizations. This concept of community consent for public health intervention is analogous to informed consent provided by patient for clinician intervention. Public health situations should provide communities with the information they have that is needed for decision on policies or programs and should obtain the community's consent to their implementation. These are a couple of strategies: community-based participatory research and community advisory boards. A couple of strategies to directly engage communities in the development and implementation of public health interventions that might be applied where they live. Community-based participatory research is an approach that involves community members in all aspects of public health research project, including addressing needs, formulating questions, devising intervention strategies, evaluating outcomes, and implementation programs and policies. Community advisory boards have been proposed as a valuable means of obtaining community input in clinical trials, especially the informed consent process, to ensure that participants are fully aware of risks, benefits, and implications. The advisory board process could also be used to engage community members in other types of public health interventions. It is important to improve our ability to know that an evidence-based public health intervention achieves its described outcome. However, formal evaluating of evidence-based public health is difficult for the reasons listed in this slide. Difficult to assess issues of sample size, contamination, blinding, long-term follow-up, ethical constraints of withholding evidence. We do know, however, from outcomes research that patients do better in the real world than provided with evidence-based therapy. They also do worse than provided with therapy that lacks evidence. Now let's look at case presentation, how to apply evidence-based medicine into the practical situation. Now let's return to the case presentation introduced at this lecture. In the following slides, we will address the issue using the steps of evidence-based medicine. Assume that you are the health director of the local health department. A community in your jurisdiction is concerned with its high rate of childhood obesity and requires your help. How do you proceed? To accomplish this initial step, it is essential to engage the community. In your role as health director, you could support the development of a task force led by a community member. This slide shows the statement of the issue such a task force developed. The prevalence of obesity among the elementary school children, among the 3,027 elementary school children of the community is 35%. With the support of patients, parents, school staff, and community-based organizations, how can this obesity rate be reduced through lifestyle interventions? Here are key pieces of information gathered as part of quantifying the issue. The prevalence of obesity was determined by a special survey. The rate of obesity was found to increase by grade level. The rates were about equal in girls and boys. 100 minutes per week provided at school for physical activity, but only 40 minutes is guided by a teacher. The next step is to search the literature using some of the resources shown at this slide: Medline resource, Cochrane Collaboration, Library Task Force of Community Preventive Services, previously described, and organize the information. As part of your research, you find that the task force made the following assessment regarding physical activity intervention: insufficient evidence to recommend classroom-based health education to provide information on managing health risks. Strongly recommended curricula and policies to increase the amount of moderate or vigorous activity, increase the amount of time in physical examination class, or amount of time being active in physical examination classes. A community-based work group develops a number of options to increase physical activity in school. And there are debates about losing time in the classroom and impact on test performance. We need to develop some action plan. The next step is to develop an action plan, which consists of next actions. Agreement is reached on a pilot project for the next school year involving reducing the lunch hour and increasing time in physical education, with an emphasis on activities that get all children to be active. And second step, the program will be evaluated by all stakeholders. Children will be surveyed. There are some critics of ABM, evidence-based medicine. They emphasizes patient values, doesn't account for individual variation, devalues clinical judgment, and leads to the therapeutical nihilism. Some of the more common criticisms are listed at this slide. The definition of evidence-based medicine explicitly requires consideration of clinical experience and patient values, which argues against the first and the third charges. One can argue, of course, whether or not evidence-based medicine is actually uh, practiced this way. Medicine and science are based upon observing patients and probabilities. The fact that the vaccine has 100 effectiveness due to individual variation does not mean that one should fail to be aware of consensus guidelines regarding immunizations and ignore such guidelines in practice. Thus, the second critic has been subject to counter arguments. The final criticism that evidence-based medicine can lead to nihilism, doing nothing if there aren't extensive randomized controlled trials justifying an intervention, has also been challenged into the evidence-based medicine uh, reliefs of the best available evidence, not or an idealized standard. We will summarize this part. Evidence-based medicine has transformed the practice of medicine by providing the techniques to access and improve the science based on which critical decisions are made. The success of evidence-based medicine has led to evidence-based approaches in a number of fields. Evidence-based public health is relatively young um, in its development and continues to evolve. Increased community engagement is an important and desirable part of this evaluation. We finish with the basics in using evidence-based medicine, and let's look for some practical applications of evidence-based medicine. Is it possible to evaluate different diagnostic and screening tests? Let's start from the definitions. First of all, what is called diagnostic tests? Any diagnostic tests should be correctly classify individuals by disease status. Tests are used in medical diagnosis, screening, and researches. How well is it answers next question. How well is a subject classified into disease or not disease group? Ideally, all subjects who have the disease should be classified at having the disease and vice versa. Practically, the ability to classify individuals into the correct disease status depends on the accuracy of the test, among other things. Why we need to use a diagnostic test? Because we need information about our patient, and we need information to make a decision. Information is usually a result from a test. Um, all medical tests to screen for a risk factor, so-called screen test, to diagnose a disease, diagnostic test, and to estimate a patient's prognosis, prognostic test. So there are three different types of tests: screening test, diagnostic test, and prognostic test. Then and whom a test should be done. Then information from the result have a value. What is the main differences between diagnostic test and screening test? A diagnostic test is used to determine the presence or absence of a disease, then a subject shows signs or symptoms of the disease. A screening test identifies asymptomatic individuals who may have the disease. The diagnostic test is performed after a positive screening test to establish a definitive diagnosis. At the next slide, you see some examples of common screening tests, such as pap smear for cervical dysplasia or cervical cancer, fasting blood cholesterol for heart disease, fasting blood sugar for diabetes, blood pressure for hypertension, mammography for breast cancer, PSA test for prostate cancer, fecal occult blood for colon cancer, ocular pressure for glaucoma, PKU test for phenylketonuria in newborns, TSH for hyperthyroid and hyperthyroid. I think you've done some of these screening tests during your life. To understand how to estimate diagnostic test, we need to give some definition for some terms, some features. Validity is the ability of the test to indicate which individuals have the disease and which do not. There are two main features of diagnostic tests: sensitivity and specificity. Sensitivity is the ability of the test to identify correctly those who have the disease. Specificity is the ability of the test to identify correctly those who do not have the disease. How to define sensitivity, specificity of a new test. We need to know the correct disease status prior to calculation. If we're talking about new diagnostic test, we need to know about gold standard test. Gold standard test is the best test available nowadays in the specific field, and gold standard test is the best test in indicating specific diagnosis. It is often invasive or expensive. A new test is, for example, a new screening test of a less expensive diagnostic test. To compare gold standard test with the new test, we need to use 2x2 table to compare the performance of new test to the gold standard test. Look at this. Gold standard tests often confirm the presence or absence. Look. Gold standard tests often confirm the presence or absence of the disease. Let's denote presence of disease D plus, absence of disease D minus. Properties of gold standard test are the next one. As usual, ruling in the disease, often doing well, ruling out the disease, maybe not doing well, feasible and ethical. Let's look how to compare new test with gold standard test. The question is, How accurate is the new test? To answer this question, we need to calculate sensitivity and specificity. Then we need to calculate two more features, such as a likelihood ratio for positive test result and likelihood ratio for negative test result. We need to calculate posterior probability or post-test probability, uh, positive and negative predictive values given prior probability or pre-test probability. Let's try to explain these terms. To calculate, we need to use 2 by 2 table for validating a test. In this table, there are two columns with disease present and disease absent. And there are two lines with test results positive and test result negative. A, B, C, and D are the number of patients who underwent this test. The general number of all the patients underwent test is A plus B plus C plus D. To calculate sensitivity, we should use a column with disease present. The sensitivity is the proportion of patients with disease, proportion of patients who get test positive among all the patients with the disease. To calculate specificity, we should use column with disease absence. It is proportion of patients who get test negative among all the patients without this disease. The value should be represented in percent style. Our patient's question as usual is, doctor, how likely am I to have this disease? This question answers predictive values. Sensitivity and specificity don't answer this question because they work from the gold standard. Now you need to work from the test result, but you won't know whether this person is a true positive or false positive. How accurately does a positive or negative result predict disease of health? To answer this question, we should calculate prevalence. Before you do any test, the best guide of your health diagnosis is based on prevalence. Prevalence's common conditions in this population are the more likely diagnosis. Prevalence indicates the pre-test probability of disease. From the 2 by 2 table, it is possible to calculate probability by using this formula. A plus C, all the patients with disease, divide by all the patients who underwent this diagnostic test. And capital is the sum of A plus C plus B plus D, all the patients. Two more important features of diagnostic test, characteristics of diagnostic test, is the positive predicted value and negative predicted value. From the same 2 by 2 table, we can calculate positive predicted value by using formula A divided by A plus B. We need to represent these values into percentage style. Predictive value for negative result, negative predictive value. To calculate it, you need to use line with negative test result. And the formula is patients without disease divide by all the patients who get test negative. The same style, percentage style should be applied to these predictive values. Now let's to understand how does predictive value influence at the results. For example, we have two different researchers. The A research, referral hospital, and B research is primary care. We have different values, different number of patients who underwent the same diagnostic test. The first point here is that predictive value results derived. We need to calculate sensitivity and specificity for each of these examples for A and B cases, but we have different prevalence. Prevalence in the A case equals to 33%. Prevalence at the for B case is 3%. Sensitivity and specificity is the same, 9 and equals 91%. The first point here is that predictive value results derived from a hospital setting will not apply if you are using the same test in a family practice setting. The second point is that if you incrementally administer tests in a primary care setting, you are certain to get a lot of false positive. Hence, be wise in whom you test. Look at the result. Positive predictive value equals to 83%. Negative predictive value for A situation equals to 95%. For the B situation, positive predictive value equals to 33% and negative predictive value is 99.5%. So due to the prevalence, we have so different results. At this slide, you see how can we interpret the results. If we have high specificity, we have only few false positive results. So the clinician is more certain that a patient with a positive test has the disease, it rules in the disease. The higher the sensitivity, the higher the negative predictive value. The clinician can be more confident that a patient with a negative score does not have the diagnosis because there are few false negatives. So high negative predictive value can rule out a disease. How to interpret test results. Diagnostic tests are used during clinical assessment to increase or decrease the clinician's estimate of the likelihood that a client has a particular condition. A negative result for the test that is 100 sensitive can rule a condition out. A positive result for a test that is 100 specific can rule a condition in. Two more important features of diagnostic test is called as likelihood ratio, defined as the odds that a given level of a diagnostic test result would be expected in a patient with the disease as opposite to a patient without. True positive rate divided by false positive rate. Advantages of using likelihood ratios are the next one. It combines sensitivity and specificity into one number, can be calculated for many levels of the test, and can be turned into predictive values. At this slide, you see formulas, how to calculate likelihood ratio for positive test and how to calculate a likelihood ratio for negative test results. During our practical classes, you should calculate all these features and interpret it according to the sense. At this slide, let's try to understand one more way. How can we define sensitivity and specificity? At this slide, you see special type of graph, which is called a nomogram. At the nomogram, you have three axes. The left axis is pre-test probability. The middle axis is the likelihood ratio, axis for likelihood ratio, and the right axis is the post-test probability axis. How to define post-test probability? By using this type of graph. Suppose you need to calculate post-test probability. First of all, we need to put point for likelihood. We need to plot the point to the likelihood ratio on center axis, because this axis is the axis for likelihood ratio. For example, likelihood ratio equals to 20 points. So we need to put dot into the 20 point. Then next, we need to select post-test probability or prevalence of left axis. For example, prevalence equals to 30. We need to put dot into the 40, into the 30 level, 30 dot. Next, we need to draw line through these points to right axis to indicate post-test probability of disease. So we should put likelihood ratio, dot for likelihood ratio. We should put dot for pre-test probability, and then we need to draw a line through these 2 points until this line crosses right axis. The result, look, according to this example, post-test probability equals approximately 30 or 93%, 91%. Interpretation, how to interpret this result. In a population with a base rate of 30 prevalence, a patient with a positive score in this test is more than 90% likely to have the disease. The test has greatly increased the information you have on this patient, but a test with a likelihood ratio of 20 is a good test, according to the final result. Next practical use look and last part of our lecture is how is it possible to measure disease? How can we define risks and then make use of this information? According to the evidence-based medicine, it is possible to estimate, it is possible to measure disease and define some different types of risk. Clinicians are required to know or make estimates of any different things, of many things. The occurrence of disease in a population, the risk of developing a disease or an outcome. So they should make prognosis, the risks and benefits of proposed treatment. Risk. What is called risk? Risk is the chance that something will happen with negative outcome. Risk can be useful for seeing how well a treatment works. Information of the effect of the treatment can be presented in several different ways by calculating different types of risks. There are absolute risk, relative risk reduction, absolute risk reduction, and one more characteristics, number needed to treat. Let's look and let's try to understand what is each feature for. First of all, to calculate different types of risks, we should use 2x2 table with information about some method to treat the patient. At this slide, you see some clinical intervention study with two outcomes, positive outcome, negative outcome. In the top line, you see treatment group. Treatment group means group with patients with intervention, and control group. Control group means patients without any treatment, or patients who took the placebo. A, B, C, and D are the number of patients in appropriate groups. Before we calculate relative risk, we should calculate absolute risk. Absolute risk is the proportion of patients with negative outcome divided by all the patients in the treatment group. So risk in the treatment group is calculated by using this formula. It is possible to calculate absolute risk in the control group by using the same formula, risk in the control group. Look at the examples. If we use real numbers instead the letters A, B, C, and D, and let's use a real example. Endoscopic ligation, Vorsa endoscopic sclerotherapy for bleeding esophageal varices. So the treatment group was given ligation, and in the control group sclerotherapy. Outcomes. Negative outcome is the death, and persons with positive outcome, persons who survive. According to this table, risk in the treatment group equals to 0.28. If we convert it into percentage style, we get 28% in the treatment group, and risk in the control group equals to 0.45. If we use percentage style, we get 45% absolute risk in the control group. Risk in the treatment group and risk in the control group are the risks of death in the treatment and control groups respectively. Risk in the control group is often referred as the baseline risks. After we calculate risks for each group, we can calculate relative risk. A relative risk. Definition of the relative risk. Look at this slide. The relative probability or risk of the event in the treatment group compared to the control group. Relative risk is denoted as RR, and we use formula risk in the treatment group divided by risk in the control group. According to our example, relative risk equals to 0.062. We use decimals. Look at the clinical interpretation, how to interpret this value and how to understand this value. The clinical interpretation should be like this one. The death rate after ligation treatment is 0.62 times lower than the death rate after sclerotherapy treatment. A measure of relative risk is a measure of the efficacy of a treatment. Null value means equals to 1. If we get relative risk less than 1, we can make our conclusion that this treatment decreased risk or this treatment is beneficial. If we get relative risk greater than 1, we can make conclusion that this treatment is harmful, and by using this method, the risk will be increased. Relative risk not a very useful measure of the clinical impact of treatment. We need to calculate absolute risk reduction, the next feature, the next characteristics. Look, relative risk reduction, 3R, RRR. The proportion of the baseline risk that is removed by therapy. To calculate relative risk reduction, we need to subtract 1 minus a relative risk. In our example, relative risk reduction equals to 0.38 or 38%. Look at the clinical interpretation. The death rate is 38 lower after ligation treatment compared to sclerotherapy treatment. Relative risk reduction indicates by how much in relative terms the event rate is decreased. Also calculated as the absolute risk reduction divided by the baseline risk. Look, if we use some different formula, we get the same result, 80 or 38%. The null value equals to null. So if we get relative risk reduction equals to 0, this means the treatment has no effect. Absolute risk reduction. Definition. The difference in absolute risk or probability of events being the control and treatment between the control and treatment groups. Absolute risk reduction difference. You need to subtract risk in the control group minus risk in the treatment group. In our example, absolute risk reduction equals to 0.17. How to interpret it clinically? The absolute risk of death is 17 lower when ligation treatment compared to sclerotherapy treatment. So 70% of patients would be spared the event death if they received ligation as opposite to sclerotherapy, or 17% is the absolute excess risk that a patient faces if treated with sclerotherapy. Absolute risk reduction is a simple and direct measure of the impact of treatment. Also be called the risk differences of or attributable risk. The absolute risk reduction depends on the background baseline risk, which can vary markedly from one population to another. Null value for absolute risk reduction equals to, if we get absolute risk reduction equals to 0, this means there is no effect in treatment. And the last important feature of treatment we can use to estimate it is the number needed to treat, N and T. The number of patients who would need to be treated to prevent an adverse event. The number needed to treat directly summarizes the effort needed to gain potential clinical benefit. How many patients do I need to treat to prevent one event? The high value for number needed to treat is bad. Low value for number needed to treat is good. The formula to calculate number needed to treat is the next one. We need 1 divided by absolute risk reduction. In our practical example, number needed to treat equals to 5.9. Approximately it is 6. Clinical interpretation for this value. For every 6 patients who received ligation treatment rather than sclerotherapy treatment, 1 death is prevented. A very useful clinical measure because it is more interpretable than the absolute risk reduction, that it conveys the impact of a clinical intervention. Number needed to treat for primary stroke prevention for statins equals to 30,000 a year. Number needed to treat for secondary stroke prevention for statins equals to 57 a year. Number needed to treat depends on the efficacy of the intervention and the underlying baseline risk. So we finish with today's our lecture. We discussed basics in evidence-based medicine. We discussed the terms we use in evidence-based medicine, and we discussed how can we estimate risk, how to estimate treatment effect, and what is the diagnostic test. We can apply this knowledge during our practical classes, and we will interpret these results in our practical life. We finish our lecture. Thank you for attention, and use this lecture in the practical classes during our first part in informatics. Bye.